All right. Hello, everyone. Thank you for joining us on this webinar for strategic planning for rural hospitals. My name is Cassidy Avila, and I'm the program coordinator for the Texas A&M Health Rural Engagement Program. We are recording this webinar, and we will share a copy of the recording with you in a follow-up email from the Rural Engagement Program. If you give us about 48 hours, we'll get that out to you. Following the presentation, we will allow time for Q&A, so feel free to drop your questions into the chat box to me or the group, and I will make sure they're addressed during Q&A. And now I'd like to take a moment to introduce our speaker, Dr. Michael Pace. Dr. Pace currently serves as Managing Director of Diverging Roads, a management consulting firm, and Vice President of Learning and Academics at GPM, where he focuses on translating complex concepts into practical applications. His approach to strategic planning is shaped by over 20 years of experience in project management, strategy, and sustainability across multiple sectors. Prior to his current roles, he served as both Director of Project Management and Director of Operations, and a 5-year stint at Texas A&M as Professor of Practice. And this summer, he'll be joining Arizona State University's faculty. Dr. Pace's unique approach to sustainability, strategic planning, project management, and leadership are informed by his background in forensic science, especially including breaking down bigger things to smaller, which you might know as decomposition, and looking in all directions for guidance. And today he'll be applying that same decomposition approach to help you create strategic plans that address the unique challenges facing rural Texas hospitals. He's passionate about helping organizations develop sustainable strategies that create lasting value and looks forward to sharing practical frameworks that you can implement immediately in your healthcare setting. So we are in great company today, and we are excited to have you. So I'm going to hand it over. That way you can get started.
All right, thanks, Cassidy, and good afternoon, everyone. I've been lucky enough to partner with the rural health folks at Texas A&M. I call it Archie. I don't even know if they still call themselves Archie, but we've been partners for a couple of years now, and this is always exciting to get to spend a few minutes to reach out to rural health institutes and hopefully provide a little bit of help. So as we go through today, like Cassie mentioned, it's a 45-minute presentation. There'll be plenty of time for Q&A at the end, but questions are really welcome. So if you have something, throw it in the chat, and then I'll try to take breaks as we talk to see if anything pops up. She mentioned all the slides will be shared afterwards. She probably has control over this, but keep your microphones muted during the presentation. We don't want to be that one person who's in case you can't hear my dog barking, that one person with the dog or the car or something like that. So she gave a great presentation or a great bio about me, so we won't talk about any of that. So today I thought we'd spend several minutes talking about some key considerations that Rural Health Institute should think about in the modern context of strategic planning. We'll walk through some of those ideas, some ways to approach that. Then we'll talk about specific frameworks that everyone should be aware of, and the difficulties of picking what could be a best fit tool or could be a worse fit tool, and try to help make sense of picking the right tool, applying it correctly, and then making use of it. And then we'll round out our conversation talking about implementation, how we can develop a deliberate, well-managed implementation plan that has accountability built in, that has measurements and timelines, and that we're tracking against progress. So with that, talk a little bit just about the rural landscape. You all are just honestly more familiar with this than anyone else, but what we're seeing kind of nationwide is that rural health hospitals are closing at an unprecedented rate. Now, we see that a lot in Texas as well, and we've got, I could throw some statistics out if you just were board and needed numbers, but we're seeing a lot of rural health hospitals closing. We see around 30% of our Texas rural health hospitals that are at some level of financial risk, and that could be for a multitude of factors. But when we say financial risk, this report was saying how they are operating in the red most of the time. Rural health hospitals and hospital systems have some unique challenges, including geographic isolation, limited resources. It could be human people. It could be the hospital itself. It could be lots of different things, staffing shortages that you wouldn't find in other healthcare settings. But in spite of these challenges, they play critical roles for that local community, and that community does depend on it. So there's a real push-pull kind of problem that exists for rural health. And as we see pretty much on the daily now, there's changing regulatory environments that require strategic adaptation. In project management, the word agile has become very much a buzzword or a drinking game at a conference because it was supposed to mean flexible and adaptable and nimble, but it has come to mean other things. And so when I say strategic adaptation, it really is this idea that whatever plan you think you have for 10 years down the road or even 5 years down the road, it may not actually work out that way because of how quickly the landscape of everything is changing. And so it does require a large degree of adaptation. So let's talk about more some of these aspects of it, of what makes rural hospital strategic planning different. It's the same tools that are available to everybody, but it's these combinations of unique challenges that really present um, an uphill battle for rural health in some ways. Geographic isolation, community dependency, we kind of talked about resource scarcity, regulations. The average travel distance to a rural health facility, or to an alternate facility rather, is around 35 miles, give or take. Now, it could be it's very much location specific, right? So if you're a farmer living next to the hospital, obviously less. But when we look nationwide, the average travel distance, so we've got this 35-mile radius that customers or patients may not have an alternative. We have, because of that, some impact on emergency response and patient transfer protocols. Where is the nearest ambulance? Where is it coming from? How can we partner with a broader ambulance community so that we can have emergency services readily available? What if we need to go to a different hospital or a different system? How do we get from point A to point B? Weather and disaster contingencies are becoming much more critical. A recent study we did, and this was a global study that we did with GPM, looking at projects that were impacted by weather due to climate change. And the vast majority, I think it was between 60 and 70% of projects had some amount of impact due to climate change. Now, as we talk about rural health, that climate change impact is going to continue. And that especially in some areas, can be even part of a problem, as we may not want to talk about climate change or admit that it's a problem, which can lead to some interesting discussions about contingency planning. We also have this growing consumer need for telehealth, which means our hospital systems need to at least figure out the infrastructure needs. Is that something they offer? How do you partner with that? As we look at our community, the average rural hospital is among the top three employers in the community. So it plays a huge role in just financial stability, let alone healthcare providing. There's a multiplier effect that each rural health hospital has. Each hospital job supports 2.3 additional local jobs. That could be the local grocer or the gas station or what have you. Now, if we look specifically at Texas, we have an aging population demographic, especially in rural areas. And what that really kind of all puts together is there needs to be strategic considerations of community partnerships. The United Nations has something called the Sustainable Development Goals. And the last of them, number 17, is that we can't do any of this work alone. And we can do that in a microcosm. That same concept applies in rural health settings, that we can't solve any problems by ourselves. We are much better off working with others towards some type of shared goal. Um, these interesting demographics, the multiplier effects, the top three employer, trying to find strategic partners, can create some interesting stakeholder groups that are unique to rural settings. I was working with a hospital system last year where we had to talk about the language that was being spoken and how do you advertise? Is it Facebook? Is it X? Is it in a print ad? Because each segment of our community it has different needs for how we communicate, and that can be very, very specific to your unique rural setting. We're no stranger to the idea of resource scarcity. The concept of do more with less is hitting everyone across the board. But if we look at rural health hospitals, the average operating margin is around 3.2%. Now, that's a number that came out pre-pandemic. When we talk about nonprofits in general, we want closer to 15, 20%. If we talk about a for-profit organization, obviously that's going to be much larger. And so we don't have a lot of wiggle room when we start talking about our operating margin. We can have critical needs around finding funding. It can be a challenge of where does the funding come from? Does it come from the county, from the state, from the federal government? And as we talk about the U.S. healthcare system, that can change on the daily, it seems like. Technology and infrastructure hurdles, something just from the Texas A&M perspective, we struggled with ongoing maintenance. And so the idea of spending money now so that you don't have to spend it later versus let's wait until something breaks and then you have to spend more money. Even within the business school, that conversation was being had. And so where do you invest and what do you invest in is an interesting and unique challenge to consider. Physician recruitment statistics are around 20% lower in a rural setting than in an urban setting. Doctors, as we try to recruit them, just don't necessarily want to go hang out in a rural health setting. And we have to work harder to get the doctors to come in. And then as we look at the frameworks that are available, not a lot of them are tooled for rural health. I mean, not a lot of them are tooled for health to begin with, but when we look at specifically rural health, it can be difficult to figure out which framework, which tool do we actually apply for our context, and then how do we make sense of that? And we'll come back to that idea here in just a minute or two. And then finally, the rural health regulatory considerations. There are specific needs that rural health has that other healthcare providers may or may not have, but we also have to think about things like Medicare, Medicaid, and the expansion or contraction of that plan. How does that impact everyone? I was working with a hospital after the assassination of the was it United Healthcare Group CEO, and it was one of those things of this is something that we have to consider because the regulations are there and we have to deal with insurance providers, but at the same time, our consumers, our patients, our customers are really getting fed up with some of this stuff. So there's some weirdness going on with that. We also have reporting requirements that are being placed upon us. Taking time to write the right codes and figuring out which codes to use. I think actually the Rural Health, Texas A&M Rural Health Institute has a course or a short course on coding because it can be just the second layer of hell, I think, sometimes figuring out which thing do you report on and which code do you use to get the most money for the procedure that you're running. The critical access hospital designation and how we can get that. And then how do we approach compliance with patient care, with limited staffing and all of that interplay. So I'm not gonna belabor any of these points. You all are very much aware there are some real challenges that are very specific to rural health that need some assistance and guidance particular to us, to our group. Which gets us into the practical frameworks. Now, I did mention I would stop in case there are any questions as we went through. So here's our first stopping point. Did anyone, I don't see anything in the chat, but if you had a question about the first half of that, the first little section of that, please holler. And I'll pause for effect. All right, we can come back for questions if any comes up. So let's talk about the frameworks. Let's talk about how do we go about actually doing a strategic plan. Uh, it's called the law of the instrument. It's also sometimes referred to as Maslow's hammer. In case you recognize that name, Maslow, yeah, same guy. And Maslow's hammer is this tendency to rely too heavily on a familiar tool or method, even when you know it's not the most appropriate tool or method. So said a different way, if the only tool you have is a hammer, everything looks like a nail. It doesn't matter what the actual challenge or problem or scenario is if you only have one tool or are familiar with one. That's your kind of learning for the week. You guys can take off early today since you've learned something. You might as well stop now, I think. But there's a challenge because there are some common frameworks everyone knows, and then there's some less common frameworks that we might not be familiar with. And again, it's this challenge of how on earth do we make sense of this? So, kind of before talking about what's on the slide, the first step in any strategic plan is knowing why you exist. Some people will call it a vision statement, a mission statement. Simon Sinek likes to say a purpose. But it's this idea, the central concrete identity of your organization is the starting point. And it doesn't matter how you do it, what framework you use, what author you prefer, but the pr the precedent before any of the frameworks is understanding why you exist. And if you don't know that, none of these tools help. Um, the starting point of any consulting engagement I have is always why you exist. And we do mission, vision, value statement workshops to determine why we exist. And that's important because if we say in our vision statement, patient care is number one, but our top three goals are finance, 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 we've now created a conflict between what we say we're going to do and what's on this plan that we're actually going to do. And so understanding who we are is the key critical first step. If you don't have that in place, none of the rest of these frameworks really matter. Now, you might be familiar with some of these frameworks, like a SWOT, which stands for strengths, weaknesses, opportunities, and threats. Um, as a professor, when I would teach SWOTs to students, they would always understand what it was, but they would never fully understand what do you do with it. So strengths and weaknesses are internal things that we have control over. External things that we have no control over are the opportunities and threats. And so we might consider things specific to our rural health setting, like community loyalty. Is the community loyal to us? Do they love us, or are they actively, seeking out a different option? Are they driving the 35 miles to a different location because they don't like our hospital system? I worked with one and we talked about paint jobs. And it seems silly, but the community loyalty was beginning to view the hospital as less than simply because the shinier object down the road. So community loyalty can be a strength or it can be a weakness. Adaptability as far as are we adaptable? Are we able to shift quickly? Or is it death by meeting and death by committee where that adaptability is slowed down? Personal care, which would require us to track how many patients are seen by each of our providers, how much time did they get with them, bedside manner and some subjective metrics come into play. Those could all be strengths. They could also fall under the weakness category if we're not careful. Limited specialty coverage could be a weakness. You have an OBGYN offering, but you don't have a cardiology offering. And so you have to find that partnership. Aging facilities, as I mentioned, it's really easy for us to kick the can of maintenance down the road, but eventually it catches up with us. My wife and I just had to replace the gutters on our house, and it was because the owners of our house prior to us didn't do any kind of preventive maintenance ever. And then all of a sudden, we buy the house and things start breaking. And so that aging facility can be a huge weakness, keeping track of that. Opportunities could be, like we mentioned earlier, the telehealth expansion. That seems to be across the board something that most rural health hospitals and systems ought to be considering. It may not work for you, but it should at least be on that list of should we talk about it. Grant funding is another option. Threats include population decline. So if you've got this great OBGYN facility, but your community is aging out and you don't have that need, you actually do need that cardiology wing instead, that's a threat that you'll have to consider. And then reimbursement changes. Like I mentioned earlier with the coding and the coding classes and making sure that insurance is paying the thing that's supposed to be paying. Now, I mentioned the idea of what do you do with this information. That kind of hidden secret underneath a SWOT is for each of these things, what you do is you find a project to overcome it, or to get more data about it. So, for example, I mentioned personal care. So as you're doing an analysis like SWOT, you identify a weaknesses, perception of customer care. You could do patient surveys. You could do nurse surveys. You could do provider surveys. You could do multiple tiers of that and determine what different demographics or segments think about the level of personal care that you are currently able to offer. And that allows you to provide, empirical evidence towards some type of future project to overcome or to solidify or strengthen that thing. So if patients think that you're the best thing since sliced bread, there's not a whole lot you need to fix there necessarily. If staff say they're not satisfied, well, that's where you put your energy and your efforts. So what we would do is identify using that SWOT framework, something to work on. If we need more data, we go out and find that data, and that becomes a goal for us or a project for us in the future. Another common framework you might have heard about is called a balanced scorecard. The idea about a balanced scorecard is great in consulting because it provokes a deliberate perspective. It focuses on finance, customers, internal processes, and learning and growth, which is cool most of the time. The problem that I personally have with it is finance is always listed on top, whereas for hospital systems, we really want customers or patients to be first. At least in my opinion. And I would say customers internal, then finance, is some kind of combination. Not that each is necessarily more important than another, but there's a bias about ordinality. So the first thing you list is always the thing that people think is the most important. Now, the idea about a balanced scorecard is you put on specific lenses or perspectives to focus on that thing. So if we say that we're going to focus specifically on finance, we could then go into specific projects around how do we strengthen our financial portfolio, how do we cut costs, how do we grow revenue, that kind of thing. And we fine tune things specific to that perspective while not ignoring the other perspectives, but knowing that we're going to get to them later. Learning and growth, for example, would be looking at how do we recruit, retain, empower our employees? How can we make sure that they're always the best at their job so that we can provide that patient care? So it's not necessarily looking at the financial impact of that yet, but it is deliberately looking at that perspective. Now, I'll show you in a minute here the idea of a customer, or it's going to be a strategy map of how these things connect, because I want to really emphasize none of these are solo, and none of them are an island unto themselves. They are all interconnected. It's simply a matter of looking at it with the best perspective. Now, from my experience, there are some less common frameworks that you may or may not have heard of, or if you've heard of it, it may be a lot harder to deploy. Um, so right in the middle, is kind of going in a weird rainbow fashion here, is this idea of the pestle analysis. Pestle comes from a guy named Michael Porter from Harvard back in the 80s. And what he suggests is looking at specific domains at what can impact or influence your industry, your region, your system. So PESTEL stands for political, economic, social, technological, environment, and legal. So under the political spectrum, we could overlay that with SWOT actually and say, okay, what politically are we okay at? Are we good at lobbying? Are we bad at lobbying? What threats exist for us? As we look at the social domain, we could say, are our populations aging out? Are we getting a lot of new people coming into our region? We could talk about the legal aspect of everything, of how partnerships work and are they available to us. We could talk about the regulations. We could talk about intellectual property, that kind of thing. And that really gives us insight about what's going on around us. The key challenge with pestle is it's things that we have to deal with that we may or may not have a lot of control over. So example, I've mentioned several times now, an aging population. Well, we would identify that using a pestle diagram or analysis or a SWOT analysis, but we may not Actually, we have zero control over an aging population. That's either going to happen or not. But it's that awareness that comes through the pestle analysis that allows us to create goals and initiatives to overcome it. The pestle analysis works really well with a SWOT diagram because it gives you a large amount of guidelines and guidance about how to look at different things. If we shift to the left here, the uh, five forces analysis. Now I'm second guessing if Michael Porter did the pestle or not, but he did do five forces. And the idea about five forces is looking specifically at you and how you're interacting with competitors. Now, in a hospital setting, we never want to think about competitors because we're in it for patient care. But from a consulting perspective, it's my responsibility to say you have to consider this. If a patient can drive 20 minutes down the road to get better care in their perspective, that's something you need to be aware of. You have competitors, it's just a matter of where are they and what can you do about it? If you're on the border between Texas and a state or Texas and Mexico, a competitor could be driving across that border to get a different level of care. Now, we could talk about prescription coverage and say it's for some, it could be easier to drive to Mexico. It's a Instead of a competing hospital, you drive to Mexico. I can get all the medications I want. There are certain types of healthcare that Texas is currently prohibited from providing, which means driving across a border might be something a patient chooses to do. That is a slippery political tightrope. I think I've walked okay, so we're going to stop that. But the idea about the five forces is looking at this idea of rivalry. Every industry, every hospital, every firm is going to have a rival or some amount of rivalry. Rivalry is not bad. It helps us all be better, but we can't be ignorant of it. So we look at things about how hard it is for a new rival to come in. Every time I see a new emergency room or I don't think it's a fully emergency room, but these quick health stations that pop up here in College Station, I think how easy it is to become an emergency room because a patient doesn't know the difference between a hospital ER and this quick care thing that just popped up on the freeway that says it's cheap and easy. And that's something, again, that's this example of a threat of new entry. We have to think about buyer power. Does a consumer have a choice in healthcare? They do, unless they're with an HMO, and you have to have a referral, and then you have to have a in-network, and you have to, and we can play with that a little bit and make some better strategic choices. Supplier power is the folks that we buy things from. We saw this during the pandemic of how hard it was to buy masks. And if the one mask supplier had wanted to raise the price 1,000%, we as a hospital system couldn't have done much about that. And so understanding the amount of power a supplier has and then what we're able to do with that helps us make better decisions. And then looking at threat of substitution, how easy is it to swap from one to the other outside of healthcare, tangentially related to healthcare. I use toothbrushes as an example of substitution. And usually when I talk to college students, that's the one thing we can agree you're supposed to do a couple of times a day. And it's if you go to Target and you're trying to buy a new toothbrush, which brand are you going to buy? And most have no idea, but they say they want the pink one or the purple one or the green one or the blue one. And that's this idea that it's easy to substitute some things and it's less easy to substitute others. And we need to be aware of that. Jumping over to the other side of pestle, over to this VRIO analysis. It's great to have a purpose. It tells us where we're going. It's great to do something like SWOT and pestle and five forces because it tells us all the things that are outside of our firm that we absolutely need to be aware of. The VRIO is where we start swapping our perspective from the external deliberately to the internal. Do we have the key resources, competencies necessary to actually achieve that ultimate purpose? We want valuable, rare, inimitable, and organized competencies and resources. And there are definitions that we could go into ad nauseum, but the idea is we need to have a resource, let's say a nursing staff. We want them to be intelligent. We want them to be highly skilled and highly trained. We want it to be hard for a competitor to copy the thing that we create. We want them to be organized so that if they need to make flexible decisions or be adaptable or learn something new, they can do that. Um, I was actually just talking about this yesterday at a facility here in College Station. And I use the example of Disney World down in Florida versus Universal Studios down the road down in Florida. And the idea of how hard it is to copy a roller coaster, but at the same time, they're both doing that and they're both playing off each other and they are trying to prove to a consumer that they're valuable and that what they offer is better than the other person and that they're not falling behind. Um, that narrative, that dialogue fits within a competitive for-profit space. Nonprofits don't necessarily like to engage in that competitive mindscape, but you do have to take note of how your resources are doing. It could be that your X-ray machine is 60 years old. That's no longer providing the value that it needs to provide. It could be that you've got the best MRI and CAT scanner and insert technical machinery here. If you don't have the resources, the skilled technicians necessary to do it, it doesn't matter if you have the way cool, awesome machine. And all of that plays into consumers' perspectives about us and how we get paid by a provider, an insurance provider or a government medical provider. And it's just important for awareness. The eroding and enabling factors idea down here toward the left side of the bottom is once you identify something you're good at, a competency, a resource, you want to make sure that you can keep it going, enable it to be the best that it can be. So if it's a nursing staff, providing learning opportunities and professional development opportunities on the regular enables them to always be the best. And you want to avoid eroding factors, the things that will slowly eat away at you being good at something. So avoiding updating your X-ray machine because it's really, really expensive means that one day you're going to be the last hospital still using the giant thunk thunk X-ray negatives that you have to develop, and it takes you 30 minutes, and you drive 20 minutes down the road, and you have the digital X-ray machine. That's a really bad example, probably, but that's what was in my head there. That you want to enable the things that you're good at to continue to be good. You want to continue to grow them, and you want to eliminate the erosion of something you're good at as long as possible. I mentioned earlier this idea of a strategy map, and that's the final box here on the page. A strategy map puts a cause and effect to those perspectives on the balance scorecard. The idea that if I can enable better processes, that enables cost reduction or cost efficiency. Now, how do I get better processes? Well, I train my staff better. If I train my staff, I can have better processes, which means I can reduce costs. And so things are linked together. We can look at it one by one, but we really should be looking at how they interconnect and the complexity of those interconnections and those dependencies. And then what? So that's just a smattering of frameworks that are available. I picked the ones that I use the most frequently, but they're not even the only ones that I use. It was simply a time perspective of what can I talk about as quickly as possible that would probably have the biggest bang for the buck, the biggest ROI. But how do you know which one is the right one? How do you pick the right one? Which requires you to know a little bit about each framework and why it's deployed and what it's going to tell you. Then after you pick it, you have to perform the analysis that it's telling you, which can be a little tricky. Um, then once you have the analysis, you have to make sense of the findings, and then how do you turn that into a plan? All that to say, uh, I would advise caution as you pull out and look at your strategic plan that you could watch a YouTube video, you can take a master class, you can take a course, you can hire a consultant. You just have to be careful at how these things are deployed so that you pick the best fit for your unique scenario. You deploy it in the best way because there are options available to you. And then whatever you find from that deployment, you turn that into a plan that is actionable and meaningful to you. Which that leads us to the third and final section of today, where we'll talk about moving towards action. I like to say hope is a sucky strategy. Um, if you don't have an action plan, everything else is just you wasting time hoping for the best, and hope is not a good strategy. What we see is plans with a structured implementation process are 3 times more likely to achieve the goals they're trying to achieve. Now, implementation is not a one-time thing. Implementation is a continuous process. It is change management, it's project management, it's stakeholder engagement. You are constantly moving toward that goal. You're using your purpose and your vision. You're informing your trajectory by all of your analyses. You're creating an actionable plan towards that preferred future. And then you're adjusting as you go because maybe that vision is the same, but you've got new roadblocks, you've got new problems to overcome. So as you work to build this implementation plan, here's some thoughts for you to consider. Um, the first question someone's going to ask is, when can this be done? So talk about timelines. You should be very realistic in how you phase your strategic plan, and you should be very realistic about how resource constrained your particular context is. In project management, we'll teach things like resource management, and we say you want to get the identify the skill the project needs and then fill that skill with the appropriate body. But as soon as you walk away from theory, what you find is you ask for a skill set, someone says Bob is available. You ask if Bob has that skill set, and they say no, but Bob is available. Or you've got Jill, who is constantly the only one doing everything because she has never failed, which means she's working 80-hour weeks and is going to burn out. So you have to be realistic about how you phase these things out. You have to treat it like a marathon, not a sprint. And that is a unique perspective you have to force upon yourself sometimes. You do have to have the short-term wins. What can you do now? And then what can you do fairly quickly after now, building up toward an investment toward that 5-year update of the strategic plan. You want to identify the critical path. Critical path is the longest sequence of activities. And the idea behind the critical path is if I know what it is, once something on that slows down, it's going to slow down my entire project. So I focus there. Things that are not on the critical path, unless they become critical path, I don't have to spend as much attention on. You should have milestones that are developed. So you meet monthly, meet quarterly, meet 6 months, but you should check in about how things are going. And I said it at the beginning, and I'll set it at the beginning of this segment, but I'll end here again. Honestly and candidly consider staff capacity considerations. Unless you're going to bring in a team to do all of your implementation, these are all people who are already probably overworked that you're about to ask to do more work on top of them. And so be very cognizant of capacity considerations. No, the first question is going to be how long is it going to take? The second question is usually how can we make it go faster? Now, the problem with that is around this idea of governance, of making decisions. And so you should clarify the leadership role that the board has, the executive team has, the CEO versus the chairman, who gets to do what in the implementation. As you figure that out, you can break it down into a RACI, or my personal favorite, it's actually called a Cairo chart. Cairo is the same thing as a RACI, but it adds the letter O, which stands for omitted. Um, I don't know if you have the same business problems that I've had in my career where Jimmy wants to sit in on every meeting, but Jimmy doesn't have anything value add. So I could put omitted next to Jimmy's name because he's not needed for this particular part of my project. And instead, I'll reduce the size of my meetings so that they can be more productive and more effective. As you start setting some ground rules for how decisions are made, you should make some meeting cadence recommendations. What makes sense for your context? Is it weekly? Is it monthly? Is it biannually? It's up to your context, but you should set the expectation and then keep people held to that. Also consider how people are going to make progress recommendations or progress tracking. If we find out that we're off of our progress, how do we course correct? And then how can we involve all of our staff in an accountability framework? So if the board or the leadership are making the decisions top down, how can we make sure that the staff gives us that bottom up direction as well? We've mentioned performance a couple of times, but you need to be very deliberate in the metrics that you select. Um, a while ago now, we talked about, or I mentioned patient care or personal care. And so you might say we want to think about the number of patients a doctor sees per day or a nurse sees per day, how much time a provider spends with each patient, how much time a patient spends in each stage of the workflow. It can be up to you, but you should be very deliberate that you are capturing the metrics that enable you to make better decisions. And there's two different flows off of that. You shouldn't collect data that you'd never need because that's just wasting effort, and you shouldn't make decisions without the data to support it. I think I was in an emergency room in Portugal where I don't speak Portuguese and was doing the best I could with my Google Translate on my phone. But I knew exactly how long the next step in the process was going to take because they had a giant television screen on the wall that said, here's my patient ID that was on my bracelet, and here's the steps of the process and how long it is in the holding area versus what's coming next, which told me they had done their homework, that they were able to track throughput of patients through their hospital system in a very objective way. And they were actually, off by a minute or two, but not by much. As you look at those metrics, what are leading metrics versus lagging metrics? What do you look at beforehand versus afterhand? How are you going to collect the data? If you're going to do patient surveys, who's going to do it? Are you going to do a survey monkey and send it out? Is it going to be the index card that's on the wall and you're supposed to drop it in the box? And I've never seen a patient actually do that, but it's an option. What strategy are you going to use to collect data for what you want to measure? How often are you going to collect it? And then how often are you going to report it out to the team? So if your team is meeting quarterly, do you only report quarterly, or do you report weekly, or some other frequency? Some folks don't like to just look at spreadsheets. So are you going to visualize the data that you have with dashboards? Is it going to be an Excel sheet? Is it going to be a Google Doc? What are you going to do to make sense of this? And again, kind of starting at the beginning and ending in the same way, metrics can be used to drive behavior, but you have to collect the metrics you want and not collect data that you're not going to use and make sense of. Um, all of the above requires intensive communication planning. You should have both internal and external focused strategies for how you're going to communicate what you're doing. So staff need to know what's going on, need to have a lot of detail. They need to be in the weeds, but your community needs to be engaged at a different level, at a different cadence with a different set of materials. You might have to report things to the board, and across all of those entities, you need to have message consistency so that when I report something to the board and it's similar that I report to the staff, but slightly different, is it consistent? It's just modified for different audiences, or is it really different? Always celebrate and publicize your wins. When you have done something way cool, awesome, take 5 minutes, take 15 minutes, publicize it. If you don't have a regular staff email or an intranet or a notice board, that's easy to start that up. Patient of the or excuse me, nurse of the week, doctor of the week, that kind of stuff. Like publicize the stuff that we're doing, because what that allows us to do is get some momentum when things get hard. Give us the motivation to overcome some of the less exciting things that will come next. And then we've mentioned adaptability, flexibility, nimbleness a few times. There are some common implementation risks for all rural health hospitals. The vast majority have to do with staff and capacity. We get staff capacity regulations, and just the overall starting point could just be the first few line items on a risk register. So there's some copy paste, and then there's some that are unique to you, where Dr. Jimmy is kind of a jerk and you have to consider him special. Well, you shouldn't write Dr. Jimmy's name, but internal stakeholder negotiation and reluctance to change is a risk that you have to overcome. You should look for early warning indicators. You want to know it's a problem before it becomes a problem. And you want that to be at an appropriate time level. You should have some type of strategy for if things go off the rails, how are you going to get it back on the rails? It's easier to have a plan and enact the plan way before you need it than to wait until it's a problem and then figure it out. You also should figure out this idea of pivot versus persevere. And that's a really hard one for a lot of organizations. Sunk cost fallacy is this idea that we continue to throw money, effort, resources at something because we've already spent so much effort on it beforehand. Now, there's that point in time, though, where yes, you need to persevere, but also, hey, we just keep wasting money. We should change things. We need to come up with a different approach, a different vision, a different strategy here. So as just a recent example, and I have tried to make this small and de-identified to protect their information, but we recently partnered with a Texas Rural Health Hospital to do a 5-year strategic plan. Um, the way we did this was through iterative discussions with their board, their executive team, and then through multiple stakeholder groups to figure out first what their vision and purpose are, and then make sure everybody was aligned with it. And then to go through those internal and external considerations and figure out what is going on around us. And through this partnership, we created 6 strategic goals, which are these big, fat, hairy, audacious goals that were supported by about 13 strategic initiatives. And I say approximately, I say about because they were debating on combining or separating a few of them out, and that's totally good with them. And then from those goals and initiatives, we created a multi-year roadmap that looked at some really quick wins, and then an 18-month, a 36, and then a 72-month perspective. When I engaged with them, it was early last fall, and I said, it doesn't matter what you think right now, because come November, there's an election, and it doesn't matter who wins. November, by December, it's all different. And then by January, it's all different. So you have to have this multi-year perspective of how you look at things and how do you chart progress. They are on track. They are doing pretty good from the last I've heard. We've checked in on them a few times now. And just kind of a high level description of how this works. It's again this iterative approach, working through frameworks, coming up with what makes sense for them or what's the biggest deal for them, and then being fully engaged with multiple tiers of their staff. All right. I technically went over my 45 minutes worth of content into our Q&A. But I appreciate y'all's attention so far. The contact information, in case you don't have it, for Rural Health, the Rural and Community Health Institute for A&M, and Melissa's information is there. They are the end-all be-all for anything you need rural health support with. If you have questions about strategic planning, my information's there and my LinkedIn information's there on the right. Melissa and the Archie folks are the first stop. I'm happy to support however I can. And with that, I will turn it back over to Cassidy to see if we had any questions that popped up throughout the course of our little discussion here.
Yeah, great. Thank you, Dr. Pace. That was wonderful. I'm looking in the chat and I don't see anything. So now is your opportunity to drop those questions into the chat or even unmute and just interrupt me right now. I'm just going to kind of talk and share some stuff until we get something in the chat or until someone interrupts me. But we are available. I'm dropping a couple of links right now into the chat for you guys. And the first link is just our website for the Rural Engagement Program. And then the second link is our technical assistance inquiry form, which would allow you to request technical assistance if you're a rural hospital in Texas and need support in something that we have available. So please do reach out. You can also reach out to our director, Melissa Lackey, whose contact information is on the screen. And I'm going to pop back over to the chat to see. Okay, it's a quiet group. I don't see anything yet. I am going to launch a poll also real quick. And if you have just a moment, it's 4 questions, and we would appreciate you filling that out. But if you think of a question after we adjourn, then please don't hesitate to reach out to one of us, and we would be happy to get your question over to Dr. Pace. Or
can I ask a question? This is Stacey Garcia. I'm at Nacogdoches Memorial. So if we signed an agreement with you guys for the Rural Engagement Program, Is this one of the elements that we could request for your assistance in developing a strategic plan for our facility?
It could potentially be, yes, absolutely. So there are a few things that it would be dependent upon, but if this is something that you're interested in, you're in Nacogdoches.
Yes, ma'am.
Okay, I will have, I believe, John Stewart, who you should possibly know or have worked with in the
Yes.
past. I will have him reach out to you.
Perfect, because they came down and I know they sent us a contract. Our CEO had signed it, and so it was just at the point where we needed to kind of understand what opportunities we had, and this is one of them that would probably be at the top of our list.
Yeah, absolutely. Well, I will have John reach out to you and make the
Perfect.
connection, and then you guys can talk about that. Thank you for unmuting.
Thanks.
Anyone else? No. Okay. Well, like I said, reach out if you have any questions after we adjourn, but it was a pleasure to be on this webinar with you today. And we hope to see you again next month. Dr. Pace, it was an excellent presentation. As always, we appreciate you and your time.
Thank you all. Appreciate it. Usually if you have no questions, it either did a really great job or everyone is already asleep. So I'm going to hope for the former and
That was
look
it.
forward to reaching out and hearing from everyone again in the future.
Wonderful. Thank you so much. Bye, everyone.